The Department of Health and Social Care have released their Major Conditions Strategy. So, this is a rather interesting document, fairly large. And in this episode, we're going to cover the executive summary that explains basically the direction of travel for major conditions healthcare treatment across the NHS. You're not going to want to miss this episode, as me and Andy basically cover everything you need to know in short form before we go into it in absolute more depth in successive episodes. So, let's get cracking as we take enhance your primary care and learning. HGB learners, and welcome to this episode where myself and Andy are looking at a rather interesting document that we came across, where we don't really think many people know about, that talks about the healthcare drive and strategy, basically for most of what general practice seems to do, isn't it, Andy?
Yeah, well, so this is a document that uses the concept of a major condition strategy. So the idea is that actually the 6 major conditions that are addressed in this document, which are cancer, heart disease, musculoskeletal conditions, mental ill health, dementia, and respiratory disease, account for actually, I think, greater than 60% of the morbidity, so the disease burden and the mortality deaths in the United Kingdom. And the idea is that if you can focus effectively on these 6 conditions, you can make a really big difference to the population health in the country, and also to how effectively you're using resources within the NHS, which of course are finite. So that's sort of the idea behind this document, as far as I can gather. So it's a really, interesting and good approach, I think.
Well, we're definitely going to have a look at it in more detail. So just to clarify, this episode, we're going to have a look at the foreword and the executive summary. It is a significantly large document with a lot of information. I know we've covered big documents before, but what we're going to do is just cover the first part, and then in successive episodes, we're going to go into the other sections in more detail. The interesting thing I found is that, as Andy mentioned, these conditions account for a significant proportion of health-driven issues. And I'm aware of certain practices, so a colleague of mine and a few others who are already kind of doing this, and they've noticed it has a profound impact on acute demand as well. So when you can do this, you've got the time to do this and the resources to do it, it can actually also have an impact on acute demand as well. So it'll be really interesting to see what this talks about and stuff, I think. Shall we have a look at the document first of all, Andy?
Yeah, so we can bring it up, and as ever, so this is a classic GP learning sort of document introduction episode. So we're going to tell you kind of what's in the document, open it up in front of you. That should reduce that friction to you picking it up and having a look. Shouldn't be quite so daunting, and it is an interesting document. So just to kind of introduce what it is really. So it's from the Department of Health, so not the NHS. So Steve Barclay's document. In fact, Steve Barclay, the Secretary of State for the Department of Health and Social Care, has written or at least signed the foreword for the document. It refers to itself as a policy paper. It also refers to itself as a blueprint within the document, and it talks about a final document coming in the future. So it acknowledges that this is an interim document, and that actually there's a bigger final document coming forwards in the future. And in terms of the structure, so pretty sort of classic NHS Department of Health structure here. There's a foreword. Often the foreword's quite interesting just to see where the emphasis is for those people who are key decision makers. So it's always worth having a look at that. There's lots of clues sometimes to future focus and direction. And then we'll be spending most of the time today just looking at the executive summary. We're dividing this up into more bite-sized chunks for people, and then in the future we'll be breaking down and probably looking at some of these chapters together over the course of what will probably be an existing 2, 3, 4 episodes. But just to give people an idea of what's coming, Gandhi, chapter 1 that looks at our nation's health. So there's lots of stats, statistics about the burden on health presented by these 6 disease areas and how that's sort of changed over time. And just a reminder, that's cancer, heart disease, musculoskeletal disorders, mental ill health, dementia, and respiratory disease. We'll come back to those a few times over the course of the episode. Chapter 2 talks about keeping people healthy, and they talk about primary and secondary prevention, empowering people to create healthy lives, those sorts of concepts. Chapter 3 focuses on early diagnosis and early intervention and quality of treatment as well. So they talk about identifying issues earlier, talk about whole-centered approach, and that's or whole person approach. And that's something that comes through quite a lot in this document, which I think is interesting. And also just an observation, the document does talk about access, but there's more of a focus here on the disease management and the care itself, which I find quite refreshing. Chapter 4, living with major conditions. So they're talking about supporting people. They talk about person-centered care again. They talk about managing complexity and the diversity and variation in care as well, and reducing that, empowering people. Talk about prehab, talk about rehab, so things before people get ill or before people have procedures, and things to help them get better more effectively. And they talk about care. And then chapter 5 talks about enablers for all of these things. So here they're talking about things like digital technology and innovation. They're talking about research, and they're talking about leadership. And we've seen leadership and leadership training talked about in the workforce plan, for example, and in other documents. So if you start looking at a few of these documents, you start to see the threads weaving together. Chapter 6 talks about the next steps, and then the annexes are actually pretty interesting. And Annex B is really, really long and talks about approaches.
Massive. It's like half the document almost, but it does include the references. So don't forget that part. And Annex A seems to talk most about the funding as well. So when we come to what funding is, being given to help enable all of this, that's majority of that is actually in Annex A as well. But we will cover those, like Andy said, in successive episodes. Shall we have a look at the forward though, Andy?
Yeah, let's have a look. I suppose the final thing to say is, Gandhi. So, Gandhi, why might people actually be interested in looking at what might feel like quite a high level policy document? As a GP or primary care clinical director, why should we be interested?
So I think the key thing with this document is the suggestion of the direction of travel for the Department of Health and Social Care. So the people that actually tell NHS England what they want to deliver in successive years. And this takes the focus, like you said, on those 6 major conditions and how they should potentially be managed and what kind of service patients should expect as a result of that in the coming future. Important future, not right now, because this is going to take time to enable. And I guess the reason why GPs in particular should be aware of this, well, absolutely, if you're in any way involved in the ICBs and that kind of stuff, this is the bread and butter of what the Department of Health is going to be asking NHS England to get you to do. But so understanding that and being able to adapt your services to what is coming is a really important thing in the future, because we know that workforce right now is just non-existent. But actually, this is what you're going to be asked to do and potentially incentivized to do in terms of how payments come through to enable this work to happen. So a massive focus on chronic disease. Does that going to impact things like, the QOF? We've talked about how there's a caretaker contract potentially being identified for the next financial year. And then from 2025, we'll have longer term ideas of what that might look like. This may set the scene for a lot of that kind of stuff from my perspective. Don't know about you, Andy. What were you thinking?
Yeah, I think these documents are always helpful, as you say, to know what's coming down the line in terms of the focus of Department of Health, NHS England, which drives your local ICS focus, which then actually has an impact on you and your funding. And it's useful to see what's coming, isn't it? Because if you're thinking about developing your services or a new idea or doing something innovative over the next 5 years, well, actually, if you choose to focus on things that are within these strategic documents, then actually you're developing something that's got a better chance of receiving the right attention, the right funding, perhaps, going forward. So it is really helpful, I think. So so shall we dive in? And
let's go for it.
Foreword by Steve Barclay. So I think we've just kind of highlighted some key phrases here. Do go away and read it if you're interested. But they're just highlighting, it's a blueprint, and it's for improving outcomes over the next 5 years. So they're not going to improve things immediately, but I think they do want to see things moving and see things improving, by the time we're getting to the end of that 5-year period. And again, I won't read them all out because it feels like I'm saying cancer, heart disease, musculoskeletal disorder, mental ill health, dementia, and respiratory disease far too often in this. So we'll stop reading them all out. But 6 disease areas, that's why it's called a major conditions strategy. What do you think about those diseases? I guess the statistics speak for themselves that those are the big sources of ill health and death in the country, and that matches my experience in general practice.
Yeah, no, I definitely agree. So, it's no surprise that cancer, heart disease, and respiratory disease are probably the 3 biggest physical burden health issues that we have existing in terms of mortality. In terms of morbidity, musculoskeletal problems are a massive challenge on the entire population, both in terms of workforce, in terms of quality of life, and just general functioning, and absolutely mental ill health and dementia. 2 key parts of the psychological well-being that twin with a lot of those things as well. Particularly mental health. We know that the chronic disease burden of physical health can have an impact on your mental health as well. So, I mean, pretty much it incorporates, as you said, the statistics don't lie. Most of the ill health issues that impact the quality of somebody's life.
Yeah, and it's interesting you talk about kind of the overlap and the twinning, as you say, the coexistence of multiple diseases in the same person, so comorbidity, because that's quite a theme in the document as well, and it talks about the rising incidence of comorbidity. 1 in 4 of us actually live with at least 2 significant health conditions, and this is rising over time, which it talks about, in chapter 1, understanding the nation's health. And it's interesting that they acknowledge that the needs of the population are changing rapidly and fundamentally, which is what we talk about a lot on this podcast, I guess, Gandhi, isn't it? People are getting older. There is more illness. Things, the need is just going up, and they talk about how the need is actually very different from when the NHS was first created and the structures were first established in 1948. So they're making a case for change. They acknowledge, obviously, Barclay acknowledges the development of integrated care systems. So they really believe that this is the right direction, and that's the right structure to join up all the components that you need to improve people's health. ICS, do you want to remind people what an ICS is, Gandhi?
So that's the integrated care systems. I think there's 42, I want to say, across the country.
Right.
Yep. And basically, these are the amalgamations of the health footprints, integrated with other services like social care and that kind of stuff, and determining how the budgets are spent to tackle both health and social well-being across the footprints that they look at. And slightly, well, the aim is for them to be more autonomous, a bit more control. It'll be interesting to see whether that becomes a reality and what resources they're given to do that. But we're still in the generative phase of that present, I would say.
Yeah, absolutely. And actually, they talk about they want to depart from the top-down approaches which have characterized the past and embrace devolution to regions in the form of ICSs, which we hear a lot of, and it still feels quite top-down to me.
Proof will be in the pudding, and right now there is absolutely no pudding whatsoever.
Yeah, but I guess they're building out these structures, aren't they? So let's see what happens in 5 years. But they're also acknowledging, but the government still plays a central role in some aspects, and they're probably right here, because they talk about actually 4 really big things like national health campaigns. Like to see more of those. Actually, I don't think they spent a lot during COVID, I guess, but I'd like to see more varied national health public health campaigns, really. But they also talk about things like the deployment and development of artificial intelligence and technology, and actually I think there's a national role, and I think they're right probably about coordinating these big things. They're probably bigger than individual ICSs, and the government or NHS England does have something to add there. So nod to the structures. There's a little bit of a description about how this report was done, really, and they talk a little bit about their process of bringing together views from not just the Department of Health, but from health, social care, unpaid carers, charities, other bodies in to form an advisory board to support this report in reaching some conclusions and recommendations. So that's good. It's interim, and alongside our call for evidence, further work, the interim report will allow us to develop our final strategy over 2023 and into 2024. So 2024, I think we'll get a final strategy. Later on, it just highlights that actually, I think the 31st of July was when the call for evidence ended. So you can't contribute to this report now.
It's an interim report that is likely to be the final report, is the way I'm reading this.
Yeah, well, I guess maybe we missed some comms. It would have been nice to talk about it before they'd had all of their evidence in. So that's interesting. Foreword, signed, Right Honourable Steve Barclay MP. Any thoughts or reactions to the foreword, Gandhi?
No, I think let's just go into the executive summary, which as many people who have watched our channel will know, this is often where the summary information of the main document is. Often doesn't have the detail we would always like, but it's a good way of getting an idea of what the document's discussing and stuff. So let's get cracking.
Yeah, I mean, tip is pick up the document, read the executive summary, look at the contents, and and then go to the bits that you think are going to be interested for you. That's the best way to approach these big documents, in my opinion. So just picking out the key themes, really. So it's a major conditions strategy. So it is about how we can tackle those 6 big disease areas. That's what it's about. It just says here, and I think they do give some more stats in chapter 1. So together, these account for 60% of ill health and early death in England, those six diseases. So that's why they're choosing to focus on them. And that sounds very sensible. And they say, actually, if we can improve these, we can have a big impact on people's lives. And that must be true. And they're setting out a framework for how they can address these, and they're taking a life course approach. So looking at, trying to intervene over the course of people's lives and the course of people's diseases. And it's all quite sensible and predictable, really. So begins by focusing on lifestyle drivers for ill health and disease. So there's a prevention focus. There's a focus on early recognition of disease and early intervention to reduce exacerbations and complications. I think, and development of disease, I would add there. Then they talk about focus on early diagnosis and early intervention and how to achieve that and how to get good quality treatment. So this is what is dealt with later in the document, but they're just telling us what the focus of the document is. And then they talk about, then once obviously we're treating people, it's about how we support people as they manage and live with conditions. And then so they talk about, so those are the main disease areas, and those are the framework with which they're talking. And then they also talk about enablers. So these are things which make it easier to meet those objectives. And they particularly talk about digital technologies and innovation, research, and leadership. So, so that's... Go on, Gandhi, were you coming in?
No. I was just agreeing with you. That's where we're at and stuff.
Yeah. The next bit's interesting. So they talk about this approach will take us away from single disease strategies. So, but they are naming kind of individual disease areas within it. But I guess those, and actually, there's very much a focus on people, isn't there? People's lifestyles, how people recognize disease and how people cope with their health. So they're trying to move away from single disease strategies. So I think that's quite interesting because the NHS is structured, in a single disease strategy. You have a cardiologist who specializes in certain aspects of management of heart conditions, for example. That's a big part of how the NHS is structured and how it needs to be, to a certain degree. So they acknowledge that the workforce model favors specialism. And actually they say, deep subject specialism unlocks innovation and redefines both outcomes and subsequent standards of care. So actually you need deep specialization. But they do talk about retaining these strengths whilst pivoting, so a shift in focus to a model that is built around whole person care. And later on in the document, they talk a lot about generalism, actually. So I think as general practice, we should feel both reassured by that, but also with that probably comes quite a lot of work and focus on what we're doing. And actually also probably a focus on medical generalism within hospitals as well, and surgical generalism. So that's a big focus of the document. I think at some point, Gandhi, we should look at these documents. It points towards similar documents that have been produced in other countries facing similar challenges as the Department of Health sees it. So they talk about a Danish government document that's looking at a similar thing, taking this multi-disease approach or multiple condition strategy, and Finland is doing something similar as well. So it'd be great to have a look at those. I think we didn't have time to bring them up or look at them today. And then they talk about access is mentioned here. We can't have a document from the Department of Health without talking about access, and access is important. But sometimes it almost feels like they need to include certain things. But they talk about inconsistent access, and that this is a challenge to delivering good care across these disease areas. So they want to design services that address these access challenges. So that's fine. And I think a lot more has been said about access elsewhere. And then they talk about how best to reconcentrate the efforts. I think these key points sort of summarized before, really, but 5 areas that will have the greatest impact across these disease areas. They talk about rebalancing the healthcare system over time towards personalized approach and prevention and management of risk. So that's, left shift, before we get to the disease, before we get to the hospital. Again, embedding early diagnosis and treatment delivery in the community. So, okay, we're community generalists, aren't we? So that means things are moving into the community where we are probably, but resources hopefully moving with it. They talk about the managing multiple conditions, so embedding generalists and specialist skills within teams. So there's talk about the importance of generalism and embedded teams. I think this might speak a bit towards neighborhood teams, and there's a lot of focus on this going forwards. What do you think that might look like, Gandhi?
I think it can occur in different ways, isn't it? Whether that means having, like you said, more generalists within the acute takes or secondary care side, so the return to generalist medical specialties, generalist surgical specialties. It's really interesting because whether that's what the workforce will move with is a separate question, because over the past 20 years it's definitely shifted towards hyper specialisms and stuff. I think within general practice, I mean it talks about effectively what general practitioners do, doesn't it? Let's be honest.
Yeah, I mean, in the community, some focus on prevention, early assessment, early identification of disease, managing multiple conditions. I mean, it really is about like the true value of general practice in a way, which is great because you can see a good future there for general practice if appropriately resourced to do the increased ask, which is probably coming for it. But maybe that's a conversation for Annex A when we get there.
But then there's potentially also the argument to be said about moving specialist services into the community to provide that generalist support. So actually, if the knowledge base is based mainly in the hospital or secondary care services, actually moving that out towards the community to back end the need and the location of the patients, maybe that's an alternative way to look at it as well.
Definitely. And actually, the last point here is about shaping services and support around the lives of people, giving them greater choice and control about where they need and want it, as in where they need and want the services. So that's good. They talk about expanding screening programs. They talk about the community diagnostic centres. So there's still a strategic focus on those. I think actually some of the plans for those are advancing in local areas anyway. I hear some things about plans in Nottingham which are really quite interesting.
And I guess with that, important to note, Andy, as you mentioned, this document seems to take strands from other documents that we've heard. This one massively seems to lean on stuff that's mentioned in the Fuller stock take that we covered about a year ago, which still seems to have huge impact on the direction of travel, I think, of the centre of where healthcare needs to go. So maybe it is worth that people review themselves of the Fuller stock take itself, because I think that's actually leading a lot of this discussion and worth being aware of.
Yeah, I agree entirely. So it again goes on to talk about using technology to identify, people at risk earlier. Talks about populations at risk, opportunistic testing in non-healthcare settings. So I'm just thinking about where, if people are thinking about what projects they've maybe been doing as practices, primary care networks, as places, as ICSs, and thinking about what to continue to do and what to stop doing. Actually, opportunistic testing in non-healthcare settings, that's in the strategic document. So maybe that's something to keep going. Just an example of how this can inform your decision making. About talking about opportunities for anticipatory care. So that's the care where you anticipate a need before it occurs, not end of life care, which is often how we within the profession think about anticipatory care. Historically, there's been a shift in terms of how they use the language, and the greater system has adopted a term which already had a specific meaning in general practice and within the medical profession. But so that's about thinking about identifying frailty and predicting need and putting things in place to mitigate that need and the things that might go wrong. Care coordination, that phrase is in there again. So that's going to be popular. Signposting, care coordination appears to have a place in the future. And then just leading into the end of the executive summary, they say they're going to need a concerted effort. They're going to need to work together with social care, patient representatives, industry, and partners across the healthcare system. I presume they mean the Royal Colleges. I presume they mean the BMA and the GPC. Hopefully, although not mentioned directly. But we can only assume that. They don't use the word professions, which normally implies that. But anyway. And then there's a nod towards levelling up. So again, this is another government agenda, isn't it? But it's important because it's about areas and communities that are left behind. So it does talk about narrowing that gap between the healthy and absolute life expectancies of people living in poor areas and rich areas, and trying to bring those in line with one another. So actually, people working in that area, it's reassuring to see that's still a focus. And corporate evidence closed on the 12th of July. So if you wanted to contribute, too bad.
You can't. Sorry.
You can't anymore. And that's right. And then finally, it summarizes that in a really nice diagram. So,
which is handy.
Yeah, and well, it's handy if you need to communicate this to other people. Then actually you can pick this up and pop it on a slide. So I think it's really helpful. And actually, it summarizes really most of what we've said. These are the 6 big disease areas in the United Kingdom. They talk about the framework, that primary prevention, secondary prevention, early diagnosis, prompt care, good urgent care, and good long-term care. And then they talk about these impact priorities, rebalancing towards proactive prevention. A lot of overlap between these, isn't there? But embedding early diagnosis and treatment in the community, managing multiple conditions effectively through aligning generalism and specialism. So it'd be interesting to see what that looks like. You do see work, don't you, trying to bring general practice closer to hospital specialists. I'm thinking about sort of the share and learn things which are being done in Nottingham, and primary secondary care interface. So I think ICS is already moving in this direction. Better connection integration between physical and mental health services, but that would be good. It's happening. And shaping services and support around people, giving them more choice and control over their care. So that's good. What it doesn't have on here is those 3 enablers, the digital technology, research, and leadership. If I was critiquing this diagram, I'd have just put them there in a box as well, because I think they're quite, they're an important part of the document. So I'd have popped them on there as well.
And it also seems like they've just missed fitting on an A4 sheet as well, by the looks of it.
That's to do with how I've exported this as a PDF, because there wasn't a native PDF version available on their website, and I like annotating the PDFs, as you can see. So that's my doing.
It's definitely how we roll when we come to reviewing these things. So as you can see, the next part that Andy's kind of scrolling down towards is the chapter 1, Our Nation's Health. Just to explain that we will be covering that in later episodes and stuff. But I guess just before we get to that, Andy, what's your initial impressions of this document?
Yeah, I think it's logical, isn't it? I guess we've begun to move in this world of reviewing these documents, over the past few years. But I've not spent, decades in this world. These documents always feel really, really logical, don't they? This feels logical. Yeah. This feels sensible. I can see that a big system like the NHS does need a strategic steer, particularly if, an ICS in Cornwall is going to be doing the same as an ICS in Newcastle, for example, and people aren't going to get completely different experiences. I think, things like this need to exist to drive it. And, and it feels like it is evidence-based, and informed by the genuine needs of people. So I think it does its job quite well. As ever, the proof of the pudding is in the delivery, and are the resources there to deliver it, both financial, workforce, and the kind of change management leadership capability at every level of the profession to do it. I don't know, but I'm sure people will have a good go. So it feels positive. It doesn't feel like, and maybe we'll find some in the detail, like there's sort of anything too controversial or unreasonable, or that we would see as not sensible within the document. But what were you thinking, Gandhi?
So yeah, the initial executive summary, like you say, outlines some really potentially sensible stuff, focusing on chronic disease and then the help with that. Like I said, having seen places where they've done that. So big shout out to Dr. Krishna Kasaneri, who's done kind of things like this over in Sheffield, where they've focused massively on chronic disease, making that the priority of delivery, and actually they've seen the impact of that in their practice about how that can then reduce acute demand, because actually you're heading off the acute problems before they've even happened. You're preventing them from actually being a reality. I know it's something that other places are looking at in terms of a model of how you deliver healthcare from primary care, but having a system align itself to these kind of principles is a really powerful thing, I think, and it'll be really interesting to see that detail, which we will absolutely be doing in the upcoming episodes and stuff. So do join us in a couple of weeks' time when you'll get to see that content and stuff coming from us directly here on the EGP Learning channel. Absolutely subscribe so you can get that. And once that's already out, you can either join us live to watch it, or you can check it in probably somewhere here. And then the following episode, because we are going to have to split this into about 2 or 3 episodes. We're not quite sure how many exactly just yet, but all that content will be coming to you. The next one might be here. And as always, we'll be here to tech enhance your primary care and learning. And we'll catch you next episode. See you later.